Okay, good afternoon, everyone. I hope you can hear me well. So it's my great pleasure to introduce you, for me in person, Dr. Pierre Jannin, who's here, who's coming from, is a research director at the Faculty of Medicine of Rennes in France, in Brittany. Is also the head of the Medicis group, part of the LTSC, Laboratoire du Traitement du Signal et de l'Image. And he's been in many important societies, has more than 30 years of experience in computer vision and computer-assisted surgery, and society like MICAI, International Society for Computer-Aided Surgery. And I know Pierre since a long time because I did my PhD with him. And it's when I started my PhD under his co-supervision that he told me that, oh, you should get yourself and trained in statistics. There is a guy in Paris who knows a bit about statistics. And exactly that's the way I met Habib Ben Ali for the first time, who became my PhD advisor. So it's my great pleasure to welcome Pierre. Pierre is here physically, so if you want to meet him, he's going to be here until the end of the year. He's doing his sabbatical at McGill right now. So welcome, Pierre. It's a pleasure to have you at home.
Thanks a lot, Christophe. Thanks a lot. It's really a pleasure to be here with you, both Christophe and Habib. We know each other more than just from the professional point of view. We had dinner together and drinks and many things. So it's personally, it's a great pleasure to see you again. And thanks a lot for inviting me to give this talk today. As Christophe said, of course, I'm open for questions at the end of the talk, but I'm also available for a few months. So if you would like to follow up with discussion about things that I will present, it will be a pleasure. So I hope you see my slides. So what I will show to you is roughly what we have done these last 20 years by trying to understand what is surgery, what are the surgical skills in order to improve surgical performance and surgical training also. And the way we did it was by implementing the study of these skills by analyzing data coming from sensors. So this is what I would like to show you with some examples on how we can use this methodology to design the OR of the future, but also how we can use this technology to improve training of surgical professionals. So as Christophe said, I'm heading a research team. It's not a big team. We are about 20-25 people working together. What is and it's also what you are here. It's a very multidisciplinary team that gathers together surgeons, clinicians, and researchers like me with engineering background, mathematics, physics, and computer science. And we are working together. We are doing research together. We are not collaborating. We are really doing research together from the beginning of the project, and this is probably our main strength of the research we do. So, what is the diagnosis regarding surgery? So, it is clear that we do surgery. I would say quite well today, but there's still room for improvement. Patients are expecting being operated earlier, I would say, in a less invasive way, so having less side effects, I would say. Also reduce the adverse events that occurs in the OR. The number is quite high, and we have a population which is more age, and so this population is expecting, of course, more surgeries. The society is looking for cheaper procedures and interventions. And there is also the notion of there is less and less experts available. So these experts are not also available for training young surgeons. So we have all these challenges coming together, and what we as a researcher in this area, what we want to do is to tackle these challenges and try to see how computer assistance may help to solve these challenges. If we, another part of the diagnosis, if we look to the evolution of surgery, we can see that at the beginning, surgery was really a surgeon himself or herself alone in front of the patient with few devices, few information, few data, few processes available. Whereas today we have a surgeon who is not alone, with a team working with him or her, with different sensors, images, signals, different knowledge also available, and very complex, I will say, very complex multimodal data, information, and knowledge to manage. And the surgeon is alone to manage that information. I mean, he has to manage it by himself or herself mentally. So the idea of how we see the next generation of surgery is the computer will help the surgeon to integrate all this information and to help the surgeon also to select what is relevant, when it is relevant, in order to optimize the surgical process. This is really the idea of what we call surgical data science. It's really try to move from a paradigm where the integration of the data and information and knowledge is done by the surgeon alone, whereas and to move to a new paradigm where the computer will help the surgeon doing this work and really provide the relevant information, provide the surgeon with the relevant information at the relevant time, depending on the context and on the patient, of course. So this is This is what we call surgical data science. Surgical data science is really the science of analyzing data for you will see for improving this integration. This is a quite new keyword that we introduced about 10 years ago. You will see it's not just for having a new buzzword and selling better our grants or whatever, or our publication. It's also because there is specificities regarding surgical data science as regard to biomedical data science in general, which was a well-known term. Because in surgery, you really have not only multimodal, heterogeneous, and longitudinal data, but you also have the how can I say, the application is really, so involve humans first. So I mean, in the therapy, the intervention, there are humans involved in this process. And so we have to take that into account. And you will see some data are related to that aspect. And also the data science aspect, where you collect data and try to understand the phenomenon and try to maybe plan what you would do, is then followed by an action, which is surgery. Surgery is really the goal of all this data processing, I would say. And the action is quite short, and the result is how can I say, is very sensitive effectively for the outcome. And so the action should be taken into account when we analyze surgery in general. So it's not about the patient only, it's about the patient, the humans involved, the processes, and this is different from biomedical data set. So I like making a flow chart and diagram. We all like that. So what is surgical data science in general? So it starts from sensors. So it starts from data collected from different sensors, images, signals, whatever. And then we move from data to information. This is the first processing step, from first analyzing step. So we collect data and then we transform this data into models that are related to what is observed by the sensors. And then we collect this, let's say, patient-specific models into data repository. And then, thanks to additional analysis method, we go from data to information and from information to knowledge. So we compute, I will say, knowledge models by analyzing population of data of subjects or patients. So there are two ways of generating knowledge. The first usual way is to generate it from discussion with experts, from modeling, from the literature, and you do it what we call it's a top-down approach. The second approach is the bottom-up one, where you generate knowledge models from analysis of data. Usually not pure data, usually it's data and information. So surgical data science is doing both. For me, it's not only the modern machine learning or data-based approach, it's also a combination of both, from data, but also knowledge coming from top-down approaches. And you will see some examples. So what surgical data science also, like any data science approaches, is when you have computed knowledge models, you can re-instantiate them for generating new information for the patient, for example. So you can call it instantiation or prediction, and I will show you some examples. Once you have done that, data, information, and knowledge can be used by what we call CAS, the computer-assisted surgical system. So you can use this data, information, and knowledge to help the different steps of surgery, from decision-making, planning, performance in the OR, post-operative assessment, and also, you will see some example, training, surgical training. So what is interesting when you use the concept of data science is this is an iterative process. So as long as you use all this data, information, knowledge to improve training, planning, performance, or post-operative assessment, you generate new data. And so all this new generated data can be reused in this process and enriched again information and knowledge. So what makes again surgical data science interesting is that there are, my computer is a bit slow, and I will have a few slides coming together as usual. So, come on boy. Yes, this wrong sign in a Apple computer when the yeah, that's it. Okay, as usual. I have probably too many videos on my presentation. So what is interesting is in surgical data science, you have, or what describes this surgical data science is you have three flows. First, you learn from data, from information, you generate new knowledge. Second, you can generate new information by instantiating knowledge. And the third flow is it is an iterative process. So as long as you generate data is coming from this flow, helps learning and helps generating new information by instantiation. So this workflow, you can do it, of course, as usually people do, based on patient data. So we know signals, images, we acquired on the patient. But what is interesting also is to do it on data generating or observing the effectors. What I mean by effectors, they are the devices involved in the surgical process or the humans involved in the process. And I will mainly focus on that aspect because this is something that that may be of interest for you. I mean, we can discuss another time about what we do on that aspect. So, what I would present is what we have done regarding surgical data science by studying effectors, the humans, the devices involved in surgeries. This is with the aim of understanding the skills involved or required by the humans to do surgery. So our objective, I can say, is to augment. We want to study the surgical skills, but we have an objective behind that is to, we can say, augment the skills of the surgeon. So it's not exactly like that because experts are already experts. What we want to do is rather to reduce the variability between surgeons and to put all surgeons at a level of experts or similar. So what are the surgical skills? The first question to ask to ourselves, what are the skills involved in surgery? So there are many skills, and I will focus on the professional skills because there are also the personal skills, but this is another story. The literature clearly distinguishes two families of skills, the technical ones and the non-technical ones. And it's the professional skills involved in surgery is a continuum between very technical one towards very non-technical ones. And I will try to explain each of them and give you examples of what we have done for each of these skills. The first technical skills from the left continuum, the most technical one, is well known, is dexterity, the dexterity of the surgeon. This is probably what we have more in mind when we think about who is an expert surgeon. We have in mind the hands of God. And this is a very well-known statue from an artist, Dante. I don't remember exactly, but in fact, what is interesting is that the quality of the dexterity of the surgeons is only, in fact, only 25% of the quality of the surgery, the global result, I would say. So, of course, dexterity is mandatory, but it's not the main factor for explaining the success of surgery. So this is important to have in mind. What is also important, an important skill for a surgeon, of course, they are what we call the conceptual knowledge. So you have to know about the anatomy, you have to know about the physiology, the pathology. So these are things which are well learned in medical schools. The third aspect, which is a bit between technical and non-technical, are the procedural skills. The procedural skills should be understood like the recipes. A surgical procedure is to apply a recipe, so you do that, and then you do that, and then you do that, and if, then, else, and then. So it's a recipe. It's a way to describe surgery definitely as a recipe. And then there is the other side, what I call the non-technical skills aspect, which are mainly related to the human factors. And we know now that the human factors aspect in the OR are crucial for the success of surgery, I would say. And there are two main non-technical skills. The first is a cognitive skill. The cognitive skills is usually also called the intrapersonal skill, which include situational awareness, risk anticipation, stress management, things like that. And the second non-technical skills is the interpersonal skills. So really being able to work with other people, and definitely surgery is the teamwork. And so you have to know how to manage teamwork. You have to know how to communicate. These are kind of interpersonal skills. There is also leadership, which is also important. And this is definitely the sum of all of these professional skills which is needed or which are needed to be a good professional, a good surgeon, an expert surgeon. So the idea, if we want to analyze the surgical skills, is really to use surgical data science to analyze each of these skills, not only based on model, but also based on data analysis. So what is the idea of surgical skills analysis with surgical data science? So that is the end of my long introduction. The idea is really to collect data taken during the surgical actions, analyze the skills or extract information and knowledge about the skills from the data. For what? For being able to improve the performance, for being able to improve the outcome. So this is the main vision. So this is why we analyze data for understanding surgical skills. So the two main applications, the two main applicative areas we are working on. The first is defining the future OR, what we call an intelligent OR. I will give you some examples. And the second one, as I said before, is to improve training by dedicating training system to dedicated surgical skills. So again, the way we do that, so the analysis with surgical data science, we collect data from different sensors. We do some analysis, different kind of analysis. Some can be, so we went from statistical to machine learning to deep learning. And then from that, we are able to have some ideas to emit some hypotheses on the skills or to better understand the skills. So what kind of sensors we can use to analyze the surgery? Any type of sensors which are available. The more we have, the better. We usually, I try to collect some of the sensors available, some of the modalities available to study surgery. It goes from, yes, medical signals and images, as we know. We discussed about EEG, even medical images. Video is an important, and you will see some example, an important source of information, source of data to understand surgery. We have also physiological signals that are collected directly on the surgeon, and kinematic data that is available from devices used by the surgeon. So now it's time to give you some examples of what we have done, starting with the skills, the different skills from technical to non-technical, and give you some example of sensor we have used and methods we have developed to study these different skills. So the first example is dexterity. So dexterity can be easily studied when you have the kinematic of the surgical stools. So we have done several experiments through robotic interfaces, where, because we use what we call collaborative robots, we are able to collect the kinematic data. Another way to collect kinematic data is to track the surgical instrument with a 3D localizer. And then you have all the gesture of the surgeon, and then you can start analyzing this kinematic data. So what we have done, we use classical kinematic features, I mean features that can be computed on kinematic data, on the path, on all the different derivatives that you can compute on kinematic data. So we have 50, 60 different features we can compute on this kinematic data, and then we can do analysis once we have acquired a lot of data. For example, one study we did recently was to, in the context of OB/GYN surgeons trying to train here for making obstetrical ultrasound. So they use a simulated ultrasound system, and we collect, it's an active system, and we are able to collect all the data, the kinematic data, for actions and tasks performed by radiologists, by obstetricians. And then we started to do the I would say the usual, the classical statistical analysis of these features and compare different populations, novices, intermediate, and experts. And we can show some aspects which are quite obvious, some other a bit less, regarding the technical skills, the dexterity that distinguish experts from novices, duration, acceleration, smoothness of the gestures, things like that. So we did it on simulated data, and then what we did more recently is it's not unpublished work. So we have a Da Vinci system, and we have a collaboration with the team doing the Da Vinci system, which master-slave robotic system, and we collect all the kinematic data you see here of hysterectomies, robotic-assisted hysterectomies. We are one of the lucky teams in the world that can collect all this data. We have now about 80 surgery, more than 80 surgery recorded, and so these are very recent work results, again unpublished, and we can do the same. So we are starting to do the same. So we analyze time, and we analyze kinematic features regarding the real surgery. So it's going from a very simple tasks to hours of kinematic data. So you can imagine the mess to collect the data, to analyze it, to store, or whatever. And we are starting to see differences in some global features in the OR on real clinical data. And we also develop other methods to analyze this kinematic data. One we did with Jannin. We were at the lab when the guy did the postdoc with us. So the idea is these are on simulated data. The idea is to compute locally the distance between a trajectory with an expert trajectory. So with the trajectory of a pool of experts, I would say. And for that, we use a DTW approach that we adapted as regard to sequence alignment. Well, I won't go into the details about that. But then we have really a local measure of expertise, I would say, and it allows to better understand where there are differences between novices' behaviors and experts' behavior. What we have done recently to study also this, I will say, this pure technical aspect, is try to study the posture of the surgeon in the OR, starting first by studying in a simulated environment. So that's what I told you this morning. So we collect video data, very simple RGB data from surgeons doing an arthroscopy on a simulator, and we use a system called Open Pose that we adapted to compute this the pose from a single RGB camera. What we have done is to compute some metrics on this pose to compare the posture between experts and novices, and we say some patterns. So we have a PhD student just starting on that. The paper was accepted last week. We are starting on that direction to see how we can quantitatively analyze the posture and extract some again some features. We are starting in a very classical machine learning way. So we extract features, but we want to jump to skip this aspect. These are things we can discuss. The next surgical skills. My computer is still waiting for. So I skipped the conceptual knowledge, which is more. We have done things like that, but for me, it's probably less important to present to you. To just jump to the procedural knowledge, how we study the procedural knowledge, the recipe's dimension of surgery. So the way we do it is quite simple. So we watch a surgical procedure, we observe it, we encoded what we observe, so what the surgeon is doing. So usually the vocabulary we use for doing that, just an example, is to encode what is the action performed by the surgeon, which surgical instrument, and on which anatomical structure. So the surgeon now is cutting the skin with a scalpel, and now he's pulling, I don't know, anatomical structure with instruments. Once we have a collection of observations, of different surgeries, we can start analyzing this data. We have data, and then we can start doing analysis. So this is what we have done. So what you understood, that the first important step is to, because we are observing surgery, I told you we are coding surgery, so we are jumping from a semantic area, a semantic world. And so for doing that, we have to specify this semantic, this language, and the way we do it, of course, is by defining an ontology. This is things that came from Bernard. And so we studied, can we develop an ontology of surgery? And so the idea is first to define the hierarchical aspects of an ontology, and it's a good way to manage the complexity in the description of a surgical procedure. So we say that a procedure is a list of surgical phases. Each phase it's a list of surgical steps, a list of actions, and so on and so forth. We can have a complex description of and a whole description of surgery. As I told you, to simplify, when I don't want to go into the details, we say describing surgery is describing what the surgeon is doing by a verb, an instrument, and a structure, but it's more than that. Of course, it's the timing and which ends, things like that. So this is the ontology we developed. We were quite successful in doing that because we did it as we do usually with an ontology. We involve different groups. We try to make it as a consensus, and so we did it in a European scale, but with some people from the US also. And so, how does it look? So you have an ontology. So you have the language for describing surgery, and you have this observer that has a tablet PC, and he is acquiring directly the description, so the receipt. So of course you don't disturb the surgeon. You just acquire what you see. And we have done, of course, dedicated software for that. But this is one example of the software we have done. So you can do it online in the OR, but of course you can do it from videos that you acquire during surgery, and you can post-operatively describe all the activities that are performed by the surgeon. And then you have data you can start working on. So the way we do it now, or until now, so you observe, you do it with a human observer in the OR, and you collect, you use the ontology, and you observe several surgery, and then you can analyze it. Of course, doing that is very cumbersome. You can imagine. You need to have an additional observer in the OR. Here is Laurent Riffaut. You remember him? He's a surgeon. This is Xavier Morandis, another surgeon. Only someone who knows that can be observer. Otherwise, so you need to have a clinician. So what have been done recently, these last 10 years, is to replace this manual observation, manual annotation by automatic annotation, automatic recognition of the activities by using computer vision and machine learning. So there is a lot of teams that work on that. We were also from the first one. So of course, you still need to have annotation. When you do machine learning, you need annotation. So you still need a few observations. And once you have these observations, then you can, with sensor, with data you collect, like video, you can learn in a simple or deep network, you can learn the network to automatically recognize when there is so during training, during learning, when there is a new video, you can, so I'm now starting to show you some surgical videos. For those who are quite sensitive, you can don't watch these videos. So here is cataract surgery. So that you see only by video, by doing machine learning, you can recognize automatically the main phases of cataract surgery. So you see the truth, you recognize one, and you see the features which are used to recognize the next phase. You will see the instruments will enter, and the instrument will be detected, the knife will be detected, and they will switch the phase to the new one. We also have whatever. So we did it by machine learning. Then we tried different deep learning approaches for doing that, for increasing accuracy, for being more robust, for not only recognizing high levels like phases or steps, but also activities. So you have more variability. And so we can with computer vision, we have a lot of tools that we can adapt for these surgical videos. We did also some years ago some automatic segmentation of surgical instruments within there was real-time recognition within the surgical microscope videos. But we can do other things. We did it also with other kind of. What is interesting to see here is how robust can be with deep learning. Even the needle is tracked, even with a large occlusion, the needle is still tracked by and recognized by the deep network. So this method that we developed with the Japanese colleagues was very robust. There was a simulator of very simple images, but still there was to demonstrate what we can do. Another studies we did, so to track the humans, the actors within the video of the OR, and it's also helpful for knowing what is happening in the OR. So we did that. We did also, can we recognize from video, which is data, some events like smoke or bleeding. So of course, computer vision allows that to. We still need to improve. We are not at 100% accuracy, and it doesn't mean anything, of course. But there are things we can do by doing this automatic recognition of action and events. We also study how we can recognize the activities from the kinematic data only, not video, which is quite a rich source of data, but from kinematic data. We demonstrated that these are things we can do. And on these automatic recognition approaches, there is a lot of teams working on that. So we organize 2 challenges at PKI by providing the data, the ground truth, and let's the team compete. And that was very interesting to do. Right, let's keep that. Okay, so once you have data, collecting on the process, on the procedural dimension, you can do it manually or automatically. You recognize the content of the information extracted from the data. You collect it from several procedures, surgery, and now you can start developing analysis method that are dedicated to this type of semantic data. And we did a lot of publication on that because there was few things available. So these are, for example, how you can represent surgical procedures from a procedural aspect. So the first things you do with this data is to compare. You compare population. You do statistical analysis based on the words, based on the durations. So these are easy to do. But what we also did, which was what more interested, is to also try to implement DTW approaches, sequence alignment approaches, which are well adapted to compare sequences of sequences, like genes or whatever. And we use this, we adapted the same approaches, and we were able to demonstrate that just by comparing the recipes that are described by sequence of activity, phases, or steps. Just by comparing with DTW, we are able to you recognize this type of dendrograms. We are automatically able to recognize the data acquired in one hospital. So we did it in Germany, in France, and in Canada. And we can completely automatically separe these clusters. And we can also, within these clusters, when you look to the subclusters, you can recognize the level of expertise. And even when you go at certain levels, this one, you can recognize the surgeon himself or herself. So there is really a signature, a procedural, a sequential signature of, it means, I will say, quite obvious. Everyone is doing it its own way, I would say, more or less. And if you are at the same hospital, the more or less is better than, it's less than more. And when you go through different hospitals worldwide, but the variability is more important. What we study also is the variability of the procedures across time in the longitudinal way. So we follow the surgeon during 3-4 years. We recorded all the surgical procedures. We translated it into a receipt with this ontology, and we computed the distances between these procedures. And similarly, we see the learning, the usual learning curve, where there is a steep acceleration, and then there is like a plateau. When you consider that you are a good surgeon being here, knowing that here you are still operating patients, so you are learning on patients, and we'll come back to that earlier. We also computed entropy between them, so then we can do whatever we want. We can play with these different analysis methods. I want to explain that. What is interesting also is when you have collected different data, you can compute knowledge models, as I said, in surgical data science. And what are knowledge models here? That are, you gather individual recordings, individual surgeries into a tree, a graph, and then you compute a graph which represents the variability of a surgical procedure across your observations. So, and then you can start playing with all the graph theories, and you can try to represent by a Petri net, for example. So this is a cataract surgeries, that a Petri net representing cataract surgeries computed automatically from observation of surgical procedures. What we have done also, which is quite interesting, is how we can not only compare I would say the invariance between the surgical procedures and the whole surgeries, but try to look for small sequences of activities which are similar. So, and the hypothesis what surgeons are not doing the whole procedure in the same way, but probably some parts of it are very similar. And we found patterns that we call surgical signature by doing this kind of analysis. Okay, so I have to be a bit faster. So one application of that, of these models, is for helping training of surgeons. So what we did, we took an example, a scrum nurse preparing the surgical table in neurosurgery. We acquired 20 videos of different scrum nursing preparing the table, and we computed the graphs showing the variability. We translated this graph into a Petri net, and we gave this Petri net into a VR system to generate the scenario of the, let's say, of the game of the VR system. And so what you see here is a real scrum nurse practicing a table preparation in the VR environment, and playing with the graph, with the graph computed from observation of real procedures. And so we tested it, and we did several studies. What is interesting, of course, and you know that when you are in the VR environment, you can have access to all the trajectories of the trainee, So we develop a lot of also the same features and analysis method of kinematic data on this data to show different behaviors between learners. Very briefly regarding non-technical skills. So we study non-technical skills with psychologists. And so we did different studies in the OR, in a simulated environment for studying, for example, communication. We studied also workflow description in the OR. We talked about this morning about the dual task, and how a surgeon can react to when you ask him to or her to follow his surgery and answer to his colleague who is entering the OR for the, oh, your patient is. So workflow description is really an important challenge in the OR. 10% of the time of the surgical procedures are concerning workflow description. And we know that there is a correlation between workflow description and the outcome of surgery. So we studied that. How we implemented it into a VR system. So we did different work with psychologists. One was to work on situation awareness. So situation awareness is an important non-technical skill. So the idea is when you enter in the OR, you have to understand what is happening. Situation awareness is defined by you perceive, you recognize, you understand, and then you project, you predict the next step. And so what we did is, what we implemented is the OR of errors. So there are errors in the OR, in this OR, and you have to find the errors and to identify them. So we work about the different categories of errors that may appear in the OR. So we developed this use case. We also developed a use case on on communication on a tablet PC. So the idea is when the scrum nurse or the trainee is discovering an error, what do you do? Who do you inform? Is there a hierarchy bias or things like that? So we work with a nurse school on that. We also developed a Japanese version of our OR, our situation awareness scenario, because we were wondering, do we have the same way to train the scrum nurses or professionals in France or in a totally different culture? And so we work with Japanese colleagues, and we developed and we wanted to see also how much work do you need to transfer your VR environment, which is strongly a cultural, I would say, environment, to another one, and we demonstrated that it was not so difficult, and finally the result was the same. We tested it on French scrum nurses and on Japanese scrum nurses, and show similar results. So, okay, I told about that already. That's the end of my talk, or roughly. So I will skip that and jump directly to the conclusion. So what we want to do? Okay, just the last. If I have 1 minute, just the last point. So you understood that you have data from sensors. You can understand the surgical skills by machine learning, computer vision, data science. What is interesting also is to correlate these skills to the results of the surgery, to the performance, to the quality of surgery. So of course, you have to define what are the criteria of quality or performance, but the idea is to see if you can correlate what you observe with the outcome, understand, predict. So we did that, and we see that with machine learning, you can sometimes go through the features to do this analysis. We did it on the simulated data. We did it on real clinical data also, how we can predict the quality of one action just by analyzing the video, how we can prevent or predict an adverse event, the events of an adverse event, just by analyzing the surgical videos. So it's really you have the recognition embedded somewhere here, and you go directly to prediction to the prediction of surgical events. So you understood. So if you want to assist surgeons, it's a use case, of course, surgery. You understood me. If you want to assist surgeon in the performance or in the training, you have to take into account the whole spectrum of the surgical skills, from technical to non-technical skills. What we propose is to do it by data science, so by analyzing data. But you saw also that we do also top-down approaches. For example, when we define an ontology, is really a top-down approach. So for me, I think the idea is really to follow the both approaches, the database approach and the model-based approach. Of course, there are still a lot to be done in surgical skills analysis. The skills are interdependent, so it's difficult to remove a dependency. We need to increase the sensor and to have more multimodal sensors. So I did not mention, but we also study EEG, how we can put EEG on surgeons to have an analysis of the non-technical skills aspect. I don't mention that, but these are things we need to do. It's both important to be in simulated environments, but also in a real clinical environment, because things are a bit different. Okay, and there are globally challenges in surgical data science, which are similar to the challenges you have in artificial intelligence. So I won't go through that regarding data, validation, analysis, ethics. We can discuss. What is important and what I wanted to also explain as a message is, again, if the computers, if the devices are starting to understand how the humans are proceeding, it's not to replace them, it's really to make them working in a clever way, in an intelligent way, with the aim to have a better outcome for the patient. So it's not what I presented here. Of course, it's not my work by myself alone, but it's a teamwork with a lot of PhD students and postdocs, and these are the current people I'm working with. Thanks a lot. Sorry for this long. Was a bit late, but.
So, thank you very much for. So Pierre, thank you very much for this presentation, and then let's go to the question.
I will stop sharing. That's probably better.
Okay, thank you. Question in the chat, or they can show them.
No questions in the chat.
Do you have no question on the chat? Let me start with the question for you, because I think
An easy one.
as you know, I have only the easy one.
I know that.
So my first question is about the ontology.
Yeah.
Because the ontology depends on the way that you imagine what are the needs, how we can analyze the data, and so on. So, and this is also an iterative process. So, how the ontology intervene? I mean, in the process itself, is it mostly to get the data?
So, no, the ontology is a way to analyze data with a dimension in a semantic way. What is the main interest of semantics here is using semantics is when you recognize an action, it's a human understandable language, and it's more understandable for humans actors than features computed on velocity or the force derivatives of the. So going through the ontology gives you access to a semantic world that is easier understandable by the surgeons we are working with. And additionally, the procedure, the receipt, as this is a choice we have made. We describe the receipt by terms, by semantics, by words, by phrases, by sentences, so we wanted to do that, because this is how you find today the surgical receipt in books or in articles, you find it on this dimension or representation, or it's like a post-operative reports are words, but they, yeah, but mainly because it's a human understandable.
So my second simple question also is about the annotation. We see that the annotation is taken by a surgeon.
Yeah.
Who is so, and you replace this by more automatic way to get this information. Have you tried to compare between both?
Yeah, sure.
Yeah.
Sure. And
And
this is the way
what are the results?
this is the way you validate your
sure.
automatic method. So
That's
it's part, it's cross validation, it's part of the
Cross-validation.
game. I mean,
So-
you cannot escape from that. So the state of the art today, if you want to automatically recognize, you understood, you have phases. Roughly a surgical procedure is about 6-7 phases. You have steps. Roughly a 2-hour surgical procedure is about, let's say, 20, 30, 40 steps, no more. And then you have the level beyond, which is activities, where a surgical procedure, 2-hour surgical procedure is about 300 different activities performed by the surgeon. So according to the levels you are trying to automatically recognize, at the level of phase and steps, it works quite well now, the state of the art from videos. It's about, I would say, 80, 85, between 80 and 90% of accuracy of good recognition. When you go to the activity level, when you have more variability between the solution you want to recognize, you are about 60-70% of activity recognition. If the surgery is easier, it's about 80, but that's the limit. That's the limit, roughly. So we are not so far for being able to have a system used in the OR. Some manufacturers send it already. For example, for you have an endoscope, and they send a software. I mean, things that we develop, not ourselves exactly, but colleagues that give you statistics about your surgical procedure with an uncertainty, of course, but give you statistics, how much time you spend on the first phase during these last 50 procedures you perform. So these are things you can start to do automatically. But you still need an annotation, you know, it's learning, and so you learn from a ground truth. So you still, there are in machine learning and deep learning, there are methods that are unsupervised, that are coming, but they are not really running quite well now. But still, you need some initial annotations.
Okay. Any question from the audience?
Yes.
Yeah, go ahead.
First, thanks for the presentation. It's very interesting. I have a question. You talked a bit about it at the end, but you mainly talk about the surgeon, but it's not the only one in the room performing. So did you also study the other actors present? And did you plan to study how they interact within each other? But I guess one very good surgeon, a surgeon can be very good, the team can be very good, but they might not interact very well, and they might work well with another team, for example.
Sure, these are things we have in mind within. So yes, we studied other actors like the scrub nurses you saw. We also studied assistants. So there is usually one other surgeon assisting the main surgeon. We would like to do more, but we have to collect data. And but yes, it makes a lot of sense to study the different specialties which are in the OR, and as you say, to study the coordination between the team. There is one group in Boston that are doing very interesting work. So as I said, so you can study surgery with different sensors. I show mainly the videos, but and kinematics, but we are also collecting ECG, EMG. So I did not show that because I've enough to show you, but we are collecting so muscular activities and heart rate frequency, and try to correlate also with the dexterity, and so it's a really multimodal approach that is needed. And there is a team in Boston which are doing that with collecting together ECG, sorry, of the surgeon, assistant, scrum nurses, anesthesiologists. Everything is synchronized, and there are some very good papers that he wrote. I can send it to you if you want. And they are studying the synchronization of the stress, mainly for heart rate frequency, the synchronization of the team. And what he demonstrated is that sometimes they are definitely not synchronized, which is interesting. So some actors are very stressed and some are not at all. And sometimes there are synchronization moments in the surgical procedure where they are all at the same stress level. So these are very interesting regarding the non-technical skills, the teamwork. Yeah, these are very interesting to study, not only for developing computer assistance, but just also to understand the dynamic of a group and how we can improve, maybe with simple, such as you do here. There is not a very complex intervention afterwards. Maybe just a way of concentration or mental rehearsal or whatever so giving this information to the professional is already a first result.
Okay, developing this computer assistant system and including virtual reality within the system, is it really adding value for the surgeon, or is it something, I mean, mostly the virtual reality within the system? Is it for training mostly, or is it for real surgery? And if it's the case, so what kind of real application? I didn't see the link.
So what I presented today is VR for training. Yeah, that's what I showed. Okay. The videos were
that
VR for
sense.
training.
Yeah.
So you train. What we developed was not training the technical skills, but mainly the procedural skills and the non-technical skills. You understand it? It's quite usual, even if the procedural and non-technicals are not so well developed. But what we tested, but we did not. We have not been very successful on that. To use VR for planning. Planning surgery. So then it's for real patients. So what we did is we used the same virtual OR. We have a virtual OR that we did, which is a room of one of the neurosurgical departments in Rennes that we synthesized, we modeled. And we put patient images in this virtual OR. So it's easy. We put the MR, we segmented everything, and so all the information is in this virtual OR, and we started a study with about 12 neurosurgeons, young ones, where we asked them to go into the virtual OR before performing the surgery on this patient, and just by moving around the virtual bed, just by turning a bit the virtual patient, which was the patient they will operate the day after, how they impact the stress before surgery, before the real surgery. And there is definitely our hypothesis, it has been demonstrated in other areas, that if you do rehearsal like that, if you start understanding the environment, the complexity, once you are in the real world, you have already some, some, say, familiarity, and so the level of stress is lower. We submit a grant again, which was not successful, but that's life. Doing the same thing with patients, so trying to put the patient in the virtual OR where they will be operated the day after, trying to reduce the stress. There are some publications on that shows that if you reduce the stress, the anesthesia is easier. usually shorter, and then it impacts the patient outcome also. So it's not. So our hypothesis was if we can immerse the patient in the virtual. So yes, there are applications that, but it's not a full. The surgeon is not fully operating the virtual environment.
And my last question is about the acceptance of this system. You know, it's really difficult because it changed the mind of the neurosurgeon using this kind of system. So, so how this work? I mean, how the neurosurgeon accept to be within this special environment and use it to optimize the neurosurgery?
So, as usual, the professionals which are confident on themselves, they are not afraid, so they are interested. They want to know how they proceed. They want to know their receipt. They want to know their weaknesses. They want to know their strengths. So they play the game and they are very interested. The one who are refractory to this kind of technology are the one who, you know, it's a human. We are not self-confident, and so they are afraid and say, no, I don't want to be watched Big Brother in the war and things like that. But of course, the surgeons we are collaborating with are very interested from scratch. They were at the start with me on that. Xavier Bondi, if you remember him, and now all the surgeons working with me, because they are doing research with us, are fully open to be monitored. To be monitored with EEG, to be observed by psychologists in the OR. They are ready. They know that it's for improving their practice and the training for the younger neurosurgeons or surgeons who are coming. So they are open to that. Then there is another question in your question, which is about acceptability in a wider meaning. We studied that. So everything we did concretely, we not only test if it impacts, if it is accurate or whatever. We also test acceptability, fears maybe by professionals. So we are now strongly working with psychologists, and every study we do, we have this stats to whatever score, because it's important.
Yeah, sure. The system is running at Rennes University.
Yes.
And do you have another place?
You mean the training, or for example, the training systems?
Yeah.
We because it's quite cheap. The PR system are very cheap now. We are even trying to make it cheaper. We gave it to some collaborators in Japan or some others. Yeah, we want to disseminate it a bit more.
Okay.
And just to complete the answer regarding the acceptability, there is another dimension that we are trying to be aware. It's about although the energy consumption of our system, the cost of our system, so what we call sustainable technology. I think it's important to have this now, since we are, you see, we are developing technology. So since years and years, you know, I think at the beginning we are not very aware about the cost of our technology, the impact, ecological impact, economical impact, social impact of our research or the technologies we are developing. I think it was a mistake, so I keep this responsibility for that. I think now we have to be more aware about the impact, and sometimes small solutions have an important impact on the outcome. Like we say, putting the patient in the VR environment, that doesn't cost a lot. It's not high-tech technology. I mean, it's feasible, and it may impact a lot rather than huge robotic systems or huge. So these are part of the answer. If I may.
No, that's great. So I think that we have to stop the meeting right now. So thank you very much.
Thanks a lot.
Yeah,
Thanks a lot.
It was a pleasure having you at Perform Center. I hope we can collaborate in the area of the physiological suite that we are developing at the Perform Center, including the virtual reality in some applications.
Yeah.
Okay, well, thanks a lot. Thank you. Thank you for your attention.